Hey guys, welcome to Mr. Nurse Prep. Today we're going to be starting our cardiology series, the first video of which is going to be on CHF, which is an acronym, as most of you know, for congestive heart failure. So we're going to do a few videos in this series. Feel free to stick around. Hopefully they help you in your studying endeavors as you prepare for your nursing school exams or your NCLEX, or if you're just a practicing nurse that's hoping to get more insight and information or refresh after a few years of being out of school. As with all videos, we're going to use the same template as always, okay? We're going to talk about some background, which is, generally what's going on in this disease process, what's the physiological causes that are making this disease process occur, and what are like the variables that are usually normal that are being affected. After that, we're going to talk about what's wrong. What's wrong is the pathophysiology of that specific disease process or condition that we're discussing in that video. We're going to talk about who is going to get it, which are your risk factors, your at-risk populations for the specific condition, which, nursing professors and the NCLEX love to ask questions on that, so that's a very important area that I feel like is often under studied, at least for me while I was in school. And then the all-important, how do you know they have it? Which is our signs and symptoms and our disease presentation. Super important, again, lots of questions, usually what people spend a lot of time focusing on, and is definitely very important. So we'll spend a good amount of time in that section. After that, we're going to dive into how to fix it, which is a few different things. It's going to be your nursing interventions that you can do without, physician orders, just kind of independently in your practice as an RN. Also going to talk about some education, going to talk about some procedures that we can do, and some pharmacology. Not super in-depth on the pharmacology, but enough for you to be familiar for your nursing exams. Some programs do have do mix pharm and like their med-surg classes in one. Some do it separately. So this is going to be like a light pharm approach. I think you'll get the understanding that you need to at least get you the basics if you're studying for a pharm exam, but definitely enough if you're studying for a med-surg exam. We are looking at doing some videos on meds alone in the future, so hang tight for those. And finally, we're going to talk about what could get worse, which are your worst case scenarios, the adverse reactions, the adverse situations that can occur when these disease processes are full blown, and those are usually at least one or two questions on an exam on those, right? And there's two specifically for congestive heart failure that we're going to go over and look at. And with that, you should be able to ace those questions. So we'll get started. Okay, so we're going to get started with some background. The key thing to grasp when learning about congestive heart failure is that the main function of your heart is to be a pump for all of the blood in your body. Your heart receives deoxygenated blood, which we've represented by making it blue, from your body. And the reason it's deoxygenated is because it's already traveled through your body, and now it's, inside of your veins, and it's dropped off all of its oxygen to various tissues and organs throughout your body to allow them to continue to function, so that they can use aerobic metabolism, going all the way back to your basic, anatomy and biology courses. So all the oxygen's been used up, and we need to replenish that oxygen, or else, bad things will happen, right? So this deoxygenated blood travels through your body's veins, mainly all collecting in your inferior and superior vena cava, and it then goes into the right side of your heart. So remember, anatomical position, right? The right side is on this side over here, and the left side's over here. So this deoxygenated blood goes in through the right atrium. Here are your receiving chambers. Your ventricles are your, I guess, shooting out chambers. So after blood travels through the mitral valve, it goes into the right ventricle, and then it travels out through the pulmonary artery. Now I know what you're thinking. I thought deoxygenated blood traveled through veins. It does, except in the case of the pulmonary vasculature. In that situation, it's actually backwards. So the pulmonary artery carries the deoxygenated blood to the lungs. The pulmonary vein carries oxygenated blood back to the heart. So through the pulmonary artery, right, which is right here, we'll just draw a little arrow there, into the lungs. And then gas exchange occurs, and that blood is now oxygenated. But we need to get it to the rest of the body. It's not going to do any good sitting in the lungs or in the pulmonary vasculature. So through the pulmonary vein into the left atrium, and then down into the left ventricle, which is your most important ventricle, because its job is to get this blood to the entire body. So it's got to be really strong, really efficient to make sure that this blood gets there, so that your body can keep going through all of these processes that it needs for homeostasis. So blood travels out through the aorta, which is here. It's a really bad arrow, my apologies, to the rest of your body. So again, making sure that you understand this blood flow. Deoxygenated blood in the body, inferior superior vena cava, right atrium, right ventricle, pulmonary artery, lungs, pulmonary vein, left atrium, left ventricle, aorta, through the body is really important. That's where we're going to get all of these signs, symptoms that will come into place later when the heart isn't functioning properly as a pump, because we're going to see congestion or backup of blood in either the body or the lungs, and that's where issues are going to start to come into play. So in addition to understanding the blood flow through the heart and the rest of the body, there's also some key terms that are utilized to describe the factors at play in the function of your heart as a pump. The most important one is something called cardiac output. It's also referred to as CO if you want to abbreviate it. And cardiac output is actually an equation. It's the heart rate times the stroke volume. So the heart rate is, your beats per minute, your BPM. How many times is your heart beating in 1 minute? And your stroke volume is the amount of blood that is pushed out with each beat. So you can see how that would make your cardiac output. And a normal cardiac output for a healthy adult would be 4 to 8 liters per minute, which is a lot. It's a lot of blood. So that's really important to understand when they're talking about cardiac output. Always try and think of breaking it down into those smaller variables to get a full picture of what's going on. And then there's two terms that are kind of like a couple that are usually mentioned together that we need to discuss. The first one is preload. Preload's a little funny because it is the measurement of the amount of blood left in the heart after it beats. So that means that preload is a measure of volume. So you think, your heart beats, and it actually doesn't take out all of the blood inside of the ventricle when it fires. There's some blood that is left over, or it's the amount of blood in your heart that was not able to be expelled despite the heart pump's max effort. Some other fancy terms for this are end diastolic volume at the beginning of systole, which is a heartbeat. But the important thing to understand is that preload is a measure of volume. That will come into play when we talk about agents, pharmacology, drugs that work to reduce preload. They are volume reducing agents. Now, afterload, on the other hand, is completely different. It is not a measure of volume. Afterload is the peripheral resistance, just ignore that, against which the ventricle must pump. Or it's the force that the ventricle needs to overcome to get the blood to its intended destination. So this is a measurement of resistance. It's not a measurement of volume. So it doesn't have anything to do with the amount of blood per se, simply how much force the ventricle needs to overcome to get that blood out. And again, that will come into play when we talk about our pharmacological agents to help in heart failure and why we're using them in heart failure. Preload, volume. Afterload, resistance. Can be a little confusing, but once you get that picture in your mind, it's pretty easy to understand. At least I hope it is. And then we'd also be completely amiss if we didn't mention, we're going to draw it down here, ejection fraction, or EF. An ejection fraction is very important in heart failure. It is the percentage of blood leaving the heart with each beat. Remember, I talked about preload. There's some blood left over after systole. That means there's blood left inside of there. You would think, why isn't my heart firing out 100% of blood? Well, it's just not how you were designed, For the left ventricle, a normal EF is 55 to 70%. And for the right ventricle, it's 45 to 60%. And remember, keep in mind, that left ventricle is super important because it's pumping blood out to the entire body, not just the lungs. So that's why its percentage needs to be higher. EF is key. It is diagnostic for heart failure. It is what we can measure to determine the degree of heart failure that someone is experiencing. So all of these terms, cardiac output, preload, afterload, EF, super important to understanding clinical conversations about heart failure. So make sure you study them, understand them, write them out. You can even go through some real world examples with your cardiac output to understand exactly what's happening. There are some other terms, things like cardiac index. We won't necessarily go into those right now. Those are a little higher level things that you probably won't see on your standard nursing lecture exams. And even I wouldn't be too concerned about seeing them inside of your licensing exams. But your textbook might mention them, so I want to acknowledge their existence. These are probably the key terms you need to get a good grasp on congestive heart failure. So, now that we've discussed some background, we're going to talk about what's wrong. What's going on in heart failure? Why are we calling it heart failure? What's occurring? Well, what's happening is the heart isn't functioning properly as a pump. So instead of heart failure, you can kind of think about it in the terms of pump failure. That might be a little bit easier and help you understand exactly what's going on. The pump is not able to do its job by pumping out enough blood, and the system is getting backed up. So what I've decided to do is describe this in real-world terms based off of a situation that occurred in my own house a few weeks ago. When you think about it, abstractly, if blood isn't being pumped out properly, your blood isn't just disappearing when it's stuck in your pulmonary vasculature or inside of your heart or getting backed up in your body. It's staying in the vessels it resides in. It doesn't just disappear, And when it stays in that area where it's not able to move forward because the pump isn't working, it results in real negative consequences to the area that it's getting backed up in. As an example, in some cases, I want to preface this by explaining that I am not a plumber. I have no understanding of plumbing, and this very well could not be how a kitchen is actually set up, just to clarify. But let's imagine that your dishwasher, which is her, that's a dishwasher, and your sink, her, that's a little faucet, you see that right there, that's a faucet, are connected. If there's a problem with your dishwasher plumbing and it cannot drain properly, the water isn't going to get, when you turn it on, it's not going to get flushed out to the rest of the house the way it's supposed to. The water will stay in the dishwasher, and the water will start to pool up. And the problem is that it's going to start to back up into the sink. And you can even see, because this pump isn't working inside of the dishwasher, water is starting to overflow out of the sink, dirty dishwasher water, which is not a good situation. The failure of water to keep moving forward in and cycling out in the dishwasher is causing it to get backed up all through, if you can see this little, cross thing moving, all throughout out into the sink, and it's causing an overflow, which is damaging. That water can get out onto your countertops. That water can drip down onto the floor. If you're not home and this is going on, that's a horrible situation, right? You come home and your floors are all wet and your dishes aren't clean. That's probably the worst part about the whole thing. And you have this huge mess because the pump failed, the water backed up, and it caused an overflow, a congestion of water at the source that's behind where the pump is. We're saying that the dishwasher is the pump in this situation. Hoping that makes sense. Well, that's kind of what's occurring with heart failure, to use layman's terms. Pump isn't functioning. Pump failure. When the pump fails, everything behind that pump gets clogged because the water isn't being moved forward anymore like it's supposed to. And that causes a whole mess on whatever's on the back end of that pump, depending on where it is. Which is why it's very important to understand which part of the heart is failing. Heart failure can be described in a lot of different terms. It can be described in the phase of action. You can have pumping failure versus resting failure. Essentially, heart failure can be, here, we're just gonna make a new area right here. Heart failure can be locational, or, I think there's an E in locational, or functional. So the locational part of this means that your heart failure can either be right-sided or left-sided. Right-sided heart failure is often referred to as cor pulmonale as a general term, and then left-sided heart failure. Functional heart failure can be systolic, which is a failure in the pumping portion, or diastolic, which would mean impaired filling of the heart. So you don't want to get too bogged down in this. Usually your exams and what you need to know for nursing school, unless you're like a high level cardiology tele, or even like part of a cardiology group NP, is just to understand the locational, right? And there is even something referred to as mixed heart failure. We don't really need to get into that, but we're going to talk about the signs and symptoms in locational heart failure when we talk about that arena of heart failure. But just real quick, to go over functional heart failure, not super in-depth at all. When we talk about systolic heart failure, it's the inability of the heart to pump blood effectively. the heart loses its ability to create enough pressure to pump blood from the left ventricle out to the rest of the body. So what's going to happen is over time, these ventricles are going to get enlarged, and we'll talk about cardiomyopathy and things like that later. But the hallmark of systolic heart failure is, because this might be an exam question, so just keep an eye out for this, you're going to have decreased EF, because what's wrong? The pump, right? And remember, when you're pumping out blood, you're pumping out a percentage of that blood. So if you have an issue with pumping out blood, then that EF is going to be decreased, right? The percentage of blood that's pumped out is going to be less. That makes sense. Diastolic heart failure is the inability of the ventricle to fill during the relaxing phase, known as diastole, usually due to stiffening of the surrounding cardiac muscle. The important thing in here is that EF is going to be fine. It's going to be normal because the ventricles are able to pump just fine. They are having a problem filling, not pumping. Decreased filling is going to lead to decreased stroke volume and therefore decreased cardiac output. Usually, because the ventricles are stiff, the pulmonary and systemic vascular systems become overloaded. So this is all really important to understand. So don't get too bogged down on the functional heart failure. The locational heart failure is where a lot of the information that you're going to need to understand is going to come from. Okay, so before we start talking about the symptoms of each type of heart failure, we should discuss those who are at risk for developing heart failure. So there's kind of three broad topics or types of conditions that can lead to heart failure, and then one secret bonus one that we'll talk about. So any sort of like heart and lung chronic issues, this is heart disease or lung disease. I'm talking about things like hypertension, coronary artery disease, COPD, chronic pulmonary problems. These can cause, especially the forms of heart disease, can cause damage to the heart. Things like a MI as well can directly damage the heart by causing a lack of oxygen to the heart muscle. And all of these can lead to decreased ability of the heart to pump out that blood because they're damaging the heart. The pulmonary problems like COPD or chronic pulmonary issues can lead to heart failure by causing increased pressure on the pulmonary side because the lung compliance is decreased, and that can result in heart failure as well. The second type is a condition that I drew out here very expertly, referred to as cardiomyopathy. I had to think about that for a second. Cardiomyopathy is enlarging of the cardiac muscle, and as you see here, I kind of enlarged that here. If I was to draw the chambers, right, this is the left ventricle, and you can see that it's much bigger than the other parts of the heart. Cardiomyopathy can be caused by a lot of different conditions. It can be genetic. It can happen over time due to a variety of lifestyle things. Cardiomyopathy is kind of its own topic. But those who have cardiomyopathy have a heart muscle that is so large and overworked that the ventricles are actually less effective than more effective. The muscle is not enlarged because it's stronger. It's actually enlarged due to some sort of negative disease process that has made the heart overwork and become hypertrophed. This could be long-term alcohol usage. I think it's called like holiday heart, or infection of the cardiac muscle like myocarditis. It can also happen in young patients due to, like I mentioned earlier, a genetic reason where you can have like a genetic predisposition to having this enlarged left ventricle. So those are some reasons why you can have cardiomyopathy. And then obviously, if your left ventricle isn't functioning properly because it's so big and it's not as effective as a pump, and especially that left ventricle being the most important, arguably, section of the heart, then you're going to have decreased pumping ability, leading to the potential for heart failure. Now, in some cases, you can actually have a heart that is working too hard, and your heart would have a higher EF than is normal. Or it might be normal, but the heart isn't able to keep up with this extra workload. It's like when you take that extra class because you want to get ahead in a semester and you want to have a lighter load in the spring so you can party a little more. That's kind of what it's like. This is referred to as high output heart failure. Some examples of this would be anemia, actually, right? So in anemia, there's less oxygen in the blood. It's essentially what anemia is. So your body's able to recognize that there's less oxygen in the blood, and the heart will try to pump harder to deliver the amount of oxygen that it knows your body needs, because your heart's always trying to maintain homeostasis. So when it sees that there's less oxygen in the blood, it's going to increase its pumping ability to try and compensate for that. And that can lead to high output heart failure because your heart's pumping too much, pumping to the point of failure. Another condition is hyperthyroidism, or another term would be thyrotoxicosis. Can cause heart failure by just ramping up your basal metabolic rate. I don't know if you've gotten to the thyroid yet, but literally, like, your thyroid is the OG. It controls everything. And if your thyroid's hyperactive, you can bet your heart's hyperactive. And if your heart's hyperactive, pumping too much too fast, eventually it can go into heart failure, right? That's what we're discussing. And then a final cause could be something like an infection, or also classic sepsis, right? Can turn on your body's immune system. You can see that fever, and then usually you also see tachycardia, right? That's why when you give someone an antipyretic, you'll break their fever, and when they break the fever, the heart rate will go down. Having an infection can make you tachycardic, can lead to high output heart failure. Another cause, we'll just do a little star down here, right? Bonus cause is drug usage, okay? Specifically cocaine. Cocaine is a stimulant and can cause vasospasm in the heart, leading to heart failure because of the temporary damage to the vessels and impeding the ability of them to pump. When they're spasming, that's temporary damage, and the heart kind of freaks out for a second, isn't able to pump the way it's supposed to. I work in the emergency department as a nurse. I have seen this before. I've seen people in their mid-late 20s go into heart failure, need IV Lasix, which we'll talk about later, need cardiac monitoring, need echocardiograms because of a hard night of partying. So it might not come up on your lecture exams, but you can bet when you start working in the hospitals, especially if you work in an area where drug use is really common, you can definitely see heart failure from drug usage. Specifically, in my experience, cocaine usage is one that can happen a lot. So these are kind of the at-risk populations that you'll see. And what's the common theme here, right? You always want to think like, hopefully you can memorize all of this, and that will be helpful during the exam. But what you want to really understand when you're studying is overarching themes, right? Like I mentioned earlier, you should memorize the blood flow through the heart and through the body and how that works. And you should memorize all the signs and symptoms of heart failure for each type of heart failure. But if you just remember that core blood flow, you can figure out what the signs and symptoms are going to be. And it's the same thing with causes, right? With your at-risk populations and your potential causes of it. What's the common theme here? The common theme is that all of this is putting stress on the heart. When you have hypertension or coronary artery disease, that's putting stress on the heart by decreasing the oxygen that's getting there or making the heart pump harder, right, against this pressure in your vessels. When you have COPD and you have decreased oxygen, right, stress on your heart. Also harder for the pulmonary vasculature to keep up. An MI, a heart attack, is direct stress on the heart, right? Cardiomyopathy, heart's not pumping well enough, needs to work harder to get the same amount of oxygen everywhere. Stress on the heart. High output, stress, because it's pumping harder than it usually is due to some sort of underlying condition, right? All of this can lead to heart failure by causing stress. So just think about that. When you get a question and asks you which patient is at risk for developing heart failure, which patient is having stress on their heart, right? That's kind of how you're going to be able to narrow down which patients you want to monitor for heart failure. So, moving on, we're going to talk about how do you know they have it? What would a client with heart failure present like? What sort of signs and symptoms? What complaints are they going to offer? What are you going to see on your nursing assessment? Well, honestly, it's going to depend on what type of heart failure they're experiencing. And I'll be honest with you. In the clinical world, when patients come in, specifically into the emergency department, this is usually like a whole bag of symptoms, right? It's usually not just right or just left. There's kind of a combination of both. But for testing purposes, for nursing knowledge, for exams, and your NCLEX, this is super important to understand. And it's not that difficult to grasp if you're able to follow and keep the idea of the heart as a pump in the background of your mind, right? So we're going to talk about right-sided heart failure first, okay? And we'll talk about left-sided. Remember, we're focusing on locational, not functional. As stated earlier, with right-sided heart failure, where's blood coming to get into the right side of the heart? All right, blood is coming from the entire body to the right side of the heart. So if blood isn't adequately getting pumped out of this right side of the heart, blood's going to get backed up into where? You're right, the whole body. The effects that you're going to see aren't just one specific organ system. They're going to be systemic, right? Here, we'll even write this out. Systemic effects. It's a big deal. So there's a few more symptoms to memorize for right-sided heart failure than left-sided heart failure. But when we get to left-sided heart failure, you realize why when you're asked a question, it's going to be pretty easy to get, okay? As blood backs up into the inferior and superior vena cava, you're going to see jugular vein distension, right here in the neck. JVD, okay? That fluid that's the first point, right? Inferior, superior vena cava into the right atrium. That's not going to be happening because the right side of the heart is failing. It's not pumping properly. It's not working properly. So as that fluid backs up, that's the first spot it's going to back up to, right? Usually you can see jugular vein distension easiest when you have a patient at a slight angle and you have them turn their head to the side. And you can see those jugular veins are nice and blown up. That's because there's too much fluid in being backed up into the system. All right, JVD, classic sign. Hard to see, often forgotten about, but for testing, super important. Blood is also going to back up into, right, we'll keep going down. This whole area. What do you have here? Several different things, right? You have the GI tract. Is fluid going to back up there? Of course it is. You're going to see distension and ascites, A term for gross swelling, right? Like the entire body is called anosarcria. That's what's happening when you have like the systemic swelling because of all this fluid being backed up into your body, right? You're also going to see fluid back all the way up into the liver and the spleen. So what's going to happen there? Hepatomegaly, I think I'm saying that right, and splenomegaly. So you can see impairment of the liver and the spleen because of all this fluid backing up. Right? You can even see nausea in some situations when this fluid backs up to the intestines. Basically, the whole body minus the lungs is being backed up, with fluid. So its function of all these organs are going to be impaired. One of the largest sites and signs of heart failure can be edema, where fluid gets pushed out of the vasculature into your body tissue. You might have even seen this if you've had clinical so far, where you have old people with really swollen legs, right? Now he looks like a snowman, doesn't he? Edema. Edema is like classic nursing school questions, okay? Edema is when you have swelling in the tissues, usually the lower extremities. There's actually a scale, I believe it's +1 to +4, varying degrees of edema. When you're able to press your fingers into the legs and you take your fingers out and there's an indentation of your finger, that's what we call pitting edema, which is another sign of heart failure and a way for you to assess how bad that heart failure really is. So super important to look for classic presentation, right? In general, a few other things you can see in right-sided heart failure that aren't as often questioned, like you're not often asked questions on them, is nocturia, where fluid moves back into the circulatory system from the interstitial space and is secreted as urine, usually at night. And the skin can appear dusky, cold, and swollen just because there's so much fluid in there, right? And, you know, if the heart isn't pumping properly, we'll talk about this in another cardiac. We have a whole video on coronary artery disease, angina, and acute coronary syndrome coming out, ACS. But they can have angina because the heart is not being perfused enough. You're also going to see, and we'll talk about this in your nursing interventions, lots of weight changes, okay? Because so much fluid's being backed up out into their whole body. So they're going to have weight gain over a very short period of time, which is going to be a hallmark of a acute episode of heart failure. So that's going to be your right-sided heart failure. When you think right-sided, think systemic. All of this. Basically, everything except your lungs is going to be affected in right-sided heart failure. So now we're going to talk about left-sided heart failure, okay? Again, think back to the blood flow. The left side of the heart is supplied by oxygenated blood that comes from the lungs, right? If this side of the heart fails, blood's going to back up into the pulmonary veins and eventually the lungs. This is going to lead to respiratory manifestations. So in the last one, it was systemic. This time, it's going to be majority respiratory, okay? Because the lungs is where the fluid is going back into. You're going to have dyspnea. When you listen to them, you'll have crackles, bilateral, full fields usually, sometimes just in the bases. Shallow respirations, a big one that specifically doctors look for, and you can look for too. Orthopnea, difficulty breathing while lying down. Why? Because when they lie down, all that fluid's pressing down on them, right? And then something that would be more of like a worst case scenario would be pink frothy sputum. That'd be a sign of, pulmonary edema, which we're going to talk about later. Also, what's going on here, right? If you look in here, this is air exchange. What's happening if you're having impaired air exchange, not enough oxygen being exchanged in your lungs? It's going to lead to hypoxia. With hypoxia, what do you see? When you don't have enough oxygen circulating, you're going to have anxiety, right? You're going to have patients who are, this is supposed to be an equal sign. It looks a little funny going sideways, but anxiety, restlessness, and eventually, in really bad situations, you're going to have confusion, altered mental status because of this decreased oxygen. Oxygen is what your body needs to keep functioning properly. That's why this heart pump is so important. So those are some of the symptoms. Now, what's actually occurring, right, inside of this left-sided heart failure is it can lead to something called acute decompensated heart failure, or ADHF. Essentially, the pulmonary arteries are getting backed up with blood, and the pressure increases and causes damage to the lungs by filling them with pressure and blood. The lymphatic system, which is responsible for removing all of this excess fluid, eventually gets to the point where it can't maintain it, and that's where you have this interstitial edema, where the lungs are just being overwhelmed with fluid, causing tachypnea, so an increased respiratory rate, feelings of shortness of breath upon exertion, right? Then the alveoli themselves, right? These are these little grape clusters here, that's an alveoli, are going to fill with fluid and decrease the PaO2, the percentage of oxygen, which is going to lead to that hypoxia that I mentioned. And that's where you're going to get your other symptoms like anxiety and confusion, right? There are some other things you can see in left-sided heart failure that aren't just respiratory symptoms. You can see specifically, this was mentioned in a lot of the textbooks, signs of organ failure, like decreased urine output because of stress on the kidneys. And that's because the body is trying to compensate for this low cardiac output, right? So you can see that was mentioned. I would honestly just focus on these respiratory symptoms. That's going to be the biggest thing with left-sided heart failure. That's what we're really looking for you to understand, right? Right-sided heart failure, systemic effects. Left-sided heart failure, respiratory effects. And understand that hypoxia, anxiety, restlessness, it's not systemic. It's because of decreased oxygen. That's why it's still under the umbrella of a respiratory problem. So finally, we have to talk about, finally for this fourth section, some lab tests and some diagnostics that can be performed for you to determine, aside from signs and symptoms, that a patient would have congestive heart failure. Obviously, there's a whole gamut of tests that come into figuring out what a patient has, right? Especially, again, where I work in the emergency department, we are generalists by all intents and purposes. We are just trying to find one problem, narrow in on it, so we cast a wide net. Everyone, if you come in and you're complaining of shortness of breath upon exertion and leg swelling, some providers might just go heart failure right away. They might not even order a bunch of extra tests besides the necessary things like an EKG, CBC, BNP, BMP, maybe a D-dimer, and a chest x-ray, right? But usually we'll do a lot of testing. We'll do all of that. We'll do a troponin, if your D-dimer is high, you'll get a CAT scan of your chest. Obviously nowadays we got to test everybody for coronavirus. That could be causing these symptoms too. There are, this could be an MI. You could have an MI and then you could be in heart failure because of it, right? When you get into the clinical setting, things get a little more complicated. But from the perspective of studying for nursing exams, this is really what you have to understand, that these are the main diagnostics that you're going to be tested on. What lab tests are really important for patients with heart failure? I've drawn out a little diagram here. The main one is something called human B-type natriuretic peptide. Sounds complicated. What do we call it? I mentioned it earlier. BNP. Be very careful because sometimes the doctor will say, hey, can you order a BNP for me? And you will say, sure. Just make sure you actually put in a BNP because I have in the past switched putting BMPs and BNPs. BMP is basic metabolic panel. Most doctors order a CMP, comprehensive metabolic panel. Sometimes they just want the basic, and it can be a little, embarrassing if you order the wrong test. So make sure you understand why you're ordering what you're ordering. But so BNP, what is it? It's a protein that the heart releases when it stretches too much. So here you have a normal heart, no fluid, doing good, right? This heart right here, it's A-okay. Gets a seal of approval. It's not going to really have any BNP that's being released. But when your heart stretches like here, it's going to release BNP. Oops. Why is your heart stretching in heart failure? Because it has too much fluid in it. The more it stretches, the higher the number, the worse the heart failure. That's the big thing. The stretch response leads to the production of BNP, which you'll be able to see in a simple blood test. And these are pretty high numbers, like in the thousands, right? I've quoted BNPs at several thousand, and that's usually how you know that, sometimes a patient's normal, right? It might be around 2,000 or 3,000, but when you have patients in the 10,000 range, things like that, that's when, they really are sick and need to stay for some IV diuretics and close INOs, things of that nature, which we'll talk about. What diagnostics are important? We don't really need to go into this too much, right? Let's write out here. Diagnostics, no big deal. There's mainly two, okay? One, chest x-ray. Portable chest, usually what we're doing. Portable chest is going to check for heart failure. The radiologist can actually interpret it as heart failure by looking at the pulmonary vessels and the lungs, seeing if there's fluid in there, right? That left-sided heart failure. Looking if the pulmonary vasculature is congested. They can kind of get a picture of that in heart failure, so in a chest x-ray. But the biggie is a 2D echo or an echocardiogram. They can do this at the bedside. If they're stable, echo kind of sometimes likes to take them down into their own private room. In the ED, we do echo at the bedside a lot. It's essentially an ultrasound of the heart. It's the simplest test to actually measure the ejection fraction of the heart and each ventricle, which when it's below a certain percentage is diagnostic for heart failure. So this is like the test to test for heart failure. You get a report afterwards, you can read it, and it'll tell you the ejection fraction of each ventricle. It's really cool, really interesting, and can kind of give you an interpretation of how severe the patient's heart failure is. So those are some of the diagnostic tests for congestive heart failure. So now that we've talked about how to identify congestive heart failure in the sense of signs and symptoms, diagnostics and labs, we're going to talk about how we can fix it. And in this specific section, we're going to talk about how we can fix it as nurses alone, right? These are nursing interventions you can do without a provider's order, well, for the most part, but these are the things that don't involve giving medications or procedures, right? This is kind of like your overall practice for what you can do. And there's always good questions on this on your nursing exam, so it's important to understand these. The big idea that you need to get when you're thinking about nursing interventions is who's the main enemy, right? The main enemy here is fluid. That's a wanted poster for fluid, so that we can understand that it is harming our patient. So we want to keep it away from our patient, right? There's a few things we want to do. And number one, we want to keep an eye on it. Make sure that the patient isn't getting too much fluid. So how do we do this? With some strict INOs, right? Intake and output. Understanding the fluid that the patient's taking in, understanding the fluid that's coming out of the patient. In some cases, the doctor might even want, we're really against catheters nowadays with all the cauties and things like that, but sometimes in severe cases, they do want one placed, or even an external catheter, so that we can see exactly how much urine is coming out and how much fluid they're taking in, Remember, this is an issue of fluid being backed up and not moving around. So you want to know if they're holding on to that fluid. In addition to I's and O's, daily weights are going to be part of your order set, right? And something that you can do. Daily weights are important because a weight gain of 2 pounds or more in one day or 5 pounds in a week is significant for heart failure. They didn't just gain that weight because they're eating bad or having junk food every day. They gained that weight because of fluid that's not moving around in the system. So again, 2 pounds or more in one day or 5 pounds in a week. That is key. I've had patients that have been sent into the emergency department from their doctor's office for a weight gain of something like 9 pounds over the past week. And sure enough, they're usually in congestive heart failure and need to be admitted. So those are just two things that you can do in regards to keeping an eye on it, right? And then we're going to make sure that we do not encourage fluid. How would you encourage fluid, right? That doesn't seem to make a lot of sense. Well, you got to think back to your core science classes, right? Water follows salt, right? That's the basic principle of osmosis and gradients. So if they're taking in a lot of salt in their diet, that salt is going to promote fluid retention, not fluid loss. They already have enough of an issue with all this fluid being stuck onto them, so they don't need, your help or dietarian's help with adding salt. I mean, it's hard enough to find salt in the hospital, so this isn't a huge issue, but for questions, it's really important. They're usually on a sodium restricted diet, and by restricted, we usually mean less than 2 grams a day in sodium. So, the dietary team will really help you in figuring out that and what they can eat. Patients aren't usually big fans of that. They have like the Mr. Dash packets that are like seasoning packets without salt. So, really important, don't encourage it, right? Water follows salt. More salt in the patient equals more water in the patient, not good. And then finally, we're going to restrict that fluid. And how are we going to do this? With a fluid restriction, it's usually less than 1,000 mLs a day of fluid intake. So, how did this get over here? Sorry about that. So, these patients aren't going to be able to have, 5 pitchers of water in a day, right? They're not going to be able to take in a ton of fluid or have a lot of drinks. They might be trying to sneak drinks from staff and asking people to fill up ice pitchers, stuff like that. So you just got to keep a really close eye on that. And then, if you're hanging fluid and someone has congestive heart failure, sometimes it gets a little complicated. I've had patients that were septic, and usually nowadays when people are septic, they have a sepsis bundle, and based off their vital signs, sometimes that indicates getting a bolus of fluid through the IV that is based off of their weight in kilograms. And it can be, kind of like it's up to the provider's discretion, right? If they have a history of heart failure, do you give them all of that fluid? We're not talking a little bit of fluid. We're talking, maybe 2,500, 3,500 mLs of fluid. That's a lot. So that's always something you want to bring up to the provider and leave to their discretion, right? And also make sure that you're advocating for your patient so that they can understand, so that you can be doing what's best for them and explaining to them why you're doing what you're doing, because they might say, like, I have heart failure, why are you giving me all this fluid, So keep an eye on that fluid, eye on those daily weights. Don't encourage that fluid with low salt intake, and restrict their fluid intake so that they won't be worsening the amount of fluid in their body. So those are our nursing interventions for what we can do to help with patients who are having heart failure. So there's a few other nursing interventions that we can do that I wanted to mention real quick. And a good practice, and I'm sure you were taught in your early fundamentals and nursing classes, at least I hope you were, is the NCLEX, the ABCs, right? And what are the ABCs? Airway. Oh man, it's hard writing this way. Breathing. And circulation, right? So we always focus on prioritization of care. Hospitals are busy. It's busy taking care of patients. Not everything is an emergency, right? Even in the emergency room, not everything's an emergency. So you need to focus on who has the highest priority and which patients need your attention first, right? So any patient that has an issue with their airway, priority number 1. Any patient who has difficulty breathing, priority number 2. Any patient who has difficulty in circulation, priority number 3. So remember, a big issue with congestive heart failure is the left-sided heart failure. That affects your lungs by backing all this fluid up into your pulmonary system. So these patients are at a high risk for developing respiratory issues due to the potential for fluid overload in their lungs. So you need to keep a close eye on them to see if they're developing any sort of difficulty breathing. A big thing that might happen is something called orthopnea, where when they're lying down, their SpO2 might be decreasing, or they might be having difficulty breathing, right? And that's because of all that fluid in their lungs. So what are you going to do? Here's a situation. You go into the room and check on your patient. They're lying down. They're having a really hard time breathing. Who knows? Maybe they're even desatting a bit, right? You're obviously concerned. They're tachypnic, right? So what matters is that they're having difficulty breathing. So they're fitting in that ABC framework. So there's some basic nursing interventions you can do. You don't need to press the code blue button. You don't need to call a rapid response right away, right? There's a few things you can do to fix this before you do any of that. Basic nursing interventions. What do we learn, right? High Fowler's position. This isn't high Fowler's, but sit them up, right? Sit them up, and that might promote breathing, right? That can help prevent that orthopnea and open up that pulmonary vasculature that's just being congested with all that fluid when they're lying down. Maybe they just need a little boost of oxygen for a little bit, 2 liters, no big deal. You probably will see massive improvement in the patient when you do this. So that's just a quick example of how the ABCs are going to apply to these patients, right? They also might get winded really easily due to the extra fluid. It might be hard to move because of all of the edema, right? So you want to make sure you're helping them with their ADLs, the activities of daily living. They might need some assistance getting to the bathroom. And these are patients that are going to be going to the bathroom a lot because of the diuretics. They might need some help just moving around, especially with like therapy and things like that. So you want to make sure that you're understanding that these aren't people that are being lazy. They have a ton of fluid. They've gained in some cases earlier a couple pounds in a few days, right? It's hard to move all that weight, and especially when some of it's sitting in your lungs. So important to give these patients grace, to be their advocate, make sure you understand that they can do it, that they want to do it, and supporting them and advocating for them in that situation. Okay, so now we're going to talk about some pharmacology in congestive heart failure. And again, this is like a light approach to pharmacology, okay? If you have a core pharm class, this might be just the basics of what you need. But for some med-surg exams, this might be very helpful, right? And even for those pharm tests, I hope this gives you the core information that you'll need help with those. So there's several medications used for heart failure. It's important to understand what the intended result of those medications are, and we always want to know why we're giving something. You never want to give a medication and have no idea why you're giving it. Remember that the goal for heart failure is to reduce preload and to reduce afterload. Preload, as you recall, is a volume, right? And I've written this out here. And afterload is a pressure, right? So that would infer that preload reducing agents are ones that remove fluid by removing volume, and afterload reducing agents are ones that decrease pressure. So think to yourself, the patient has a lot of fluid, a lot of volume. What medication can you give them to remove that fluid? Well, there's a whole class of medications that are used to expel fluid. They're called diuretics, right? And there's various types of diuretics. There's loop diuretics. An example of a loop diuretic would be, here, I forgot to write this out, Lasix or furosemide. Very common. Very, very, very common. Lots of people on Lasix. I would say frontline medication for heart failure. There's potassium-sparing diuretics like spironolactone, and there's thiazide diuretics, which all end with thiazide, like hydrochlorothiazide. So how do these medications get rid of fluid? Well, they make them urinate the fluid out. They don't just take it out. They don't just like make it disappear in their body. They have to get rid of it somehow. So they use it by processing it through their kidneys. And different diuretics work on different portions of the kidneys. Some work in, the loops of Henle, and some work in different areas. But the big thing to understand is that they're working on in the kidneys to help remove this fluid by making the patient pee more. I've heard a nursing mnemonic. I'm not sure how true it is that we call it Lasix because it works for 6 hours. So take that with a grain of salt. But when you give patient's Lasix, there's a few things that you need to, and we'll focus on that. There's a few things that you need to do to be safe when you're administering it, okay? Lasix is not a potassium-sparing diuretic, which means that when it's removing this fluid, it's removing potassium with it. So monitoring the level of their potassium will be important and looking for signs and symptoms of hypokalemia. They can also eat food that is high in potassium to counteract it, right? So the answer usually on tests, I'm just going to tell you, is not bananas. It's potatoes. For whatever reason, potatoes, I don't know, ask your nutrition professor. Potatoes are the answer on the test question, okay? The answer is potatoes. It's not bananas. At least it was never bananas in my program. I was asked that question like 5 times. The answer was always potatoes. So potatoes have a high source of potassium. We're probably not talking French fries, right? We're probably talking like baked potatoes. So that is one food they can eat to increase their potassium if their diuretic is taking potassium with them, right? And that's more like in the outpatient setting. You know, sometimes you have like those sweet old ladies that like you tell them in the hospital their potassium is low and they request several bananas, but that's not going to fix it right then. We can just give you potassium pills as well if we have to, or potassium through the IV. Which again, real quick aside, if you're giving potassium through the IV, put it on a pump. And you know, you have to be very careful with the concentration, with how fast it's going. A lot of times potassium can burn through the IV. You can cut the time in half. You can open fluids into them, you know, a 250 bag as well, just to dilute it because it really burns. It's very, venocaustic, hurts when it goes through. So when you're giving potassium in the hospital, be gentle, right? Don't make patients refuse potassium every time they come because you didn't dilute it and put it in a small IV in their hand and then they're yelling at you. So rightfully so. Also, we have to think patient safety and skin integrity. Why? Because they're going to be urinating a lot, right? Since they're going to be going to the bathroom a lot, and they might not be able to ambulate due to a secondary reason, due to really bad edema. They might be confused because of hypoxia or because they are chronically confused, right? If they're an older patient and they have dementia. So you need to provide a safe method for them to void. The males are pretty easy. You can just give them the bedside urinal. It lets you measure it. It's awesome. Nowadays in the hospital for female patients, we have something called the PureWick, which is an external catheter that sits outside of the urethra. It looks like a blue banana, and it actually attaches to the wall suction and can just, the patient will urinate, it'll go into the PureWick and it'll get sucked up into the wall. Now, there's also external catheters, Texas condom catheters for male patients as well, which they will usually rip off. But, you don't want to make this patient bedbound because of their congestive heart failure. You always want to promote them to move because the more they're bedbound, you also have to think of skin integrity, right? If they are confused and they don't know how to use the urinal and they miss, that's a big deal. And they can be, we do, standard policy in the hospital is 2-hour rounds, right? But what if you have a situation where, everyone's busy, right? What if you can't get in there for 2 hours and that's on time? Hopefully you're seeing your patient more than every 2 hours. And when you go in there, they're saturated in urine, right? And they haven't moved, they haven't been turned. What's going to happen is, that's going to excoriate all of their skin and their perineal area and put them at risk for developing bed sores, or pressure injuries as well, right? So you have to find a balance, and it's kind of hard to do with making sure you're getting a good INO, you're promoting patient safety, right? If they're going to try to get up to go to the bathroom but they're not supposed to, then you better have that bed alarm on. Or have them on a 1-to-1, have them on, in our hospital, we have something called an AVAssist, which is a robot that watches them. You can also make sure you give diuretics early in the morning or at latest early in the afternoon so they won't be up all night. If someone comes to the emergency department, unfortunately, we don't have that luxury, right? If you're in acute heart failure, you're getting your dose of Lasix, even if it's 9 o'clock at night. And yes, you're going to be up all night peeing, and yes, I'm sorry. So that's important. Patient safety, always, always important. top priority minus airway, breathing, and circulation is patient safety. And also, another thing is that you want to push your diuretics slowly, okay? Why? Because if you slam IV Lasix into somebody, you can cause tinnitus. You can make their ears ring and actually have them develop hearing loss. So push it slowly, and if they complain that they're having ringing in their ears after receiving IV Lasix, you need to let someone know, because that's an adverse reaction. Now, what medications are going to reduce pressure? A variety of medications. ACE inhibitors, ARBs, calcium channel blockers, right? Those are all medications that are also used for high blood pressure. They help in a variety of different ways by working on a bunch of different systems to reduce blood pressure. And by reducing blood pressure, they're reducing that afterload. They're reducing the pressure that the heart has to overcome to push out all of that blood. So patients are usually going to be on one of those, and in some cases their CHF is caused by hypertension, so they're already on one of these medications, you know. Another one that we can use is a vasodilator, right, which is a little different. That's nitroglycerin. That's a vasodilator that works by opening up the vessels, and by opening up those vessels, it's reducing afterload because a larger vessel has less pressure than a smaller vessel, right? So nitroglycerin we'll go into more detail with in our coronary artery disease video, but just understand that it can be used, especially for acute pulmonary edema, which is one of the worst case scenarios that we are going to talk about. You can see IV Lasix is like the main medication that we'll use now. I mean, IV nitro is the main medication we'll use nowadays for acute pulmonary edema due to heart failure. It just works really fast and is able to open up that pulmonary vasculature to allow fluid to start moving. I mean, you can see x-ray images of patients a few hours after being started on nitro drips, and the improvement's incredible. The big thing with IV nitro is that it needs special tubing, and it needs to be protected from light. You know, it has this like blue tubing, and it comes in a glass bottle, at least in my facility, and in a brown bag, and you just tear a hole in the bag and pull like the tab on top of the bottle to hang it on the pump out of it and keep it covered in the bag, because the light will degrade it. So nitroglycerin has to be covered, has to use special tubing, but it works really well in acute heart failure, acute pulmonary edema. So another option, instead of just reducing the preload and reducing the afterload, is to actually increase the ability of the heart directly by improving cardiac output, by increasing the pumping ability of the heart and the contractility of the heart with a class of medications called inotropes. So there's a few different types of inotropes. You know, usually they are used in critical care situations as IV-only medications. You know, dopamine, dobutamine are examples, and they are like, you know, you're in bad shape if you're on dopamine or dobutamine, unfortunately. Those are like really, really intense medications that we would talk about in a critical care class. But the big one you'll see patients who have heart failure on is something called digoxin. That is a PO medication that patients will take. It's a bit of an older medication, and here's why. Because it requires a lot of monitoring, okay? So it's one of those medications that has a range, and that range is 0.5 to 2, and you can check that level with a simple blood test, but there are signs of toxicity that are things like nausea, right? Fatigue, confusion. I can't fit confusion in here. Whoopsie. Those are signs of digoxin toxicity. So if a patient is experiencing these kinds of symptoms and they're on digoxin, they very well might be referred to the hospital to check their digoxin level, and might have to have that addressed. So a good thing that's really important for this, and again, these are applying to digoxin, is you need an apical heart rate for 1 minute, okay? This is an intense medication, full minute apical pulse, and hold that medication if they're super tachycardic, right? Or even super bradycardic. There will be a specific range that they want you to have that heart rate in to give the medication. And you can teach patients at home to do this if they have to, right? But you don't want to rely on a peripheral pulse. You want to get that central apical pulse before you give digoxin. So these are the medications that you'll commonly see in patients with heart failure. So are there procedures that can help a patient who's experiencing congestive heart failure? Of course there are. The main one you will see and hear of is a ventricular assist device, or a VAD, V-A-D. This is an implanted device that will actually assist a heart that's too weak to pump on its own. It can be used who are waiting for a heart transplant or those who are not a candidate for a heart transplant due to their other medical condition. So as you can see here, you have this tube that has been implanted. Imagine this is all inside the heart, right? And it's coming out of the left ventricle, and it's going around to a pump that is acting as the left ventricle, kind of taking over for it. And then that pump is attached to a outside terminal, right? And that terminal you can see is being worn on the patient's chest here. So the patient does wear a vest. It's referred to as a life vest because it's keeping them alive. And the vest and the battery are literally their life source. So if they stop, it's a really, really big issue. They need to always have extra batteries with them and always need to have them charged. And VADs are a very specific thing. There's whole departments that are dedicated to patients who have ventricular assist devices. There's a bunch of different types of ventricular assist devices, and making sure these patients have a good quality of life is really important. So as you can see, it comes out of the left ventricle to the pump here, and then it goes up to the aorta. So it kind of just bypasses the work of the left ventricle for them. And what are the other procedures they can have done? Well, the only cure for congestive heart failure is are you ready? Heart transplant. That is it. That is the only thing that can actually cure congestive heart failure, because there isn't a cure. You need a new heart. Your heart isn't working properly. It's been too damaged. And the medications will help manage things and make sure that your life is, doable. And a lot of patients are just fine on those medications. But in really severe cases, the only thing that can actually fix congestive heart failure is a heart transplant. And unfortunately, a lot of patients are not candidates for heart transplants, and the waiting list can be really long. So this ventricular assist device can help bridge patients until they're ready for a heart transplant. So now we're going to talk about our last section, which is what could get worse. And remember, the largest concerns are with fluid, right? I know. We've been over this a million times, but it really needs to get through to you, right? That is what this is all about and what the main enemy is. Any complications with fluid would be if the fluid is going someplace that is dangerous. So what are the most important organ systems in the body? Again, remember your nursing alphabet, that mnemonic, ABC. Breathing is the pulmonary system, and circulation is the cardiac system. And we're going to talk about both of those when we're talking about our two main complications. The most dangerous systems to be overloaded would be the pulmonary and cardiac systems, because that's breathing and circulation. When this occurs in the lungs, it would be called pulmonary edema. And then we'll talk about when it occurs around the heart, it's called pericardial tamponade. So pulmonary edema, as you can see here, you have normal lungs, no fluid. They're good. Pulmonary edema is when a lot of fluid, as you can see, overwhelms those lungs. Those lungs, not normal. Lots of fluid in them, right? So how would these lungs sound if there's fluid in them? Bilateral diffuse crackles, right? I know we mentioned that in the left-sided congestive heart failure. A lot of these symptoms are the same as the left-sided congestive heart failure, right? It's just very severe and very dangerous, right? You can see that hypoxia that we mentioned, and a big hallmark, big sign. Test questions love to ask this. Patient suddenly develops pink frothy sputum with a history of congestive heart failure. that is your priority patient. That is who you're supposed to spend most of your time with. So if you get asked that question on which patient to prioritize care on, the one who suddenly develops pink frothy sputum, that's the patient. How do you treat this, Well, you're going to give oxygen. Usually, if they're in acute pulmonary edema and they're having a really hard time breathing, that impaired breathing is going to result in them needing some supplemental oxygen. At the very minimum, that could be a nasal cannula. But in really bad cases, they need something called positive pressure ventilation in the form of usually BiPAP or CPAP, usually BiPAP in really bad cases. These patients are going to come in, they're going to be hypertensive, they're going to be hypoxic, they're going to be tachypnic, and they're going to be tachycardic. Okay? So because of that, and why? Why, right? Because their lungs are full of fluid, They're not able, their afterload is going to be big because of all the fluid in their lungs, and they're not going to be moving anything. The pulmonary vascular is going to be all congested. So that positive pressure ventilation is going to help forcefully open up those lungs to allow for air exchange to occur, which is the most important thing. And the meds you're going to give are going to be IV medications, right? IV Lasix, IV nitroglycerin, like I mentioned earlier, because this is an emergency, right? Breathing, super important. I don't need to say that. And these patients need immediate attention, okay? Pulmonary edema, nursing emergency, medical emergency requires your attention. They need oxygen. They need IV medications. They're going to be confused, anxious, restless, hypoxic, crackles. Pink frothy sputum is the big one. Cool. Got it? All right. So here we'll do it up here. What could get worse? The second complication that can occur, we already talked about pulmonary edema, is something called pericardial tamponade. So you might be wondering, what the heck is that? That sounds super fancy. It's a little fancy. We'll get into it. This is a normal heart with a normal pericardium. Your heart's surrounded by a sac. It sits in there and it has a little bit of fluid. You can see that right there, right? A little bit of fluid. Little. To help keep things smooth, keep the heart moving, protect the heart when it gets smacked around. That's what the pericardium's purpose is, right? It helps prevent the heart from being damaged from shock and keep it nice and safe. But in the case of heart failure, it can easily be overwhelmed and fluid can begin going into the sac, causing pressure on the heart and impeding its, you can see that pressure here and here, impeding its ability to pump because of all this fluid. Not a normal pericardium, right? Fluid is overfilling the sac that protects the heart. So it's an emergency because this is affecting circulation. This is affecting the heart's cardiac output, right? There's actually a triad of symptoms that you'll see in pericardial tamponade. You're going to see hypotension because you're going to have decreased cardiac output because the heart's being compressed. So hypotension, you're going to see jugular vein distension because fluid is getting backed up into the veins. And you're going to see something called paradoxical pulse, where there's a 10-point difference in blood pressure between inhaling and exhaling. That's called Beck's triad. So you might actually just get a question on your lecture exam that says, what is Beck's triad? And you'll have to circle the 3 symptoms that make up Beck's triad. So it's important to remember that. It's something that will come up later in life as well. Additionally, you're going to hear muffled heart sounds when you auscultate the heart, right? Because it's underwater, so it's going to sound muffled. How do you treat this? I mean, there's not a lot we do unless you work in CVIR, because you need something called a pericardiocentesis, where they actually use a needle and they go into the pericardium and they remove that fluid to help decrease pressure on the heart. So that is pericardial tamponade. So guys, that concludes the video. Hope you found this helpful. Thanks for signing in today. I can't even write thanks. Wow. No, seriously, I hope this video helped you out. I hope you have a better understanding of congestive heart failure. I know this is long. I'm hoping that longer format is helping in the regards of being more like a lecture format than some smaller snippet videos. So hopefully you got through the whole thing. Please like, subscribe, leave comments, letting me know what other topics you need to see covered so that I can plan future videos for you. Thanks so much for tuning in. Hope this finds you well. Best of luck studying, and we will see you soon. Thank you.